Enteral feeding, prepared by clinical instructor Sanaa Jum'a Yusuf. Definition: it is commonly called tube feeding, involves the insertion of a tube so that feedings can be delivered directly into the child's gastrointestinal tract. Indication: it is indicated for children who have a functioning gastrointestinal tract but cannot ingest enough nutrients orally. The child may be unconscious or have a severely debilitating condition that interferes with his or her ability to consume adequate food and fluids. Other conditions that may warrant the use of enteral feeding include failure to thrive, inability to suck or tiring easily during sucking, abnormalities of the throat or esophagus, swallowing difficulties or risk for aspiration, respiratory distress, metabolic conditions, severe gastroesophageal reflux disease, surgery, severe trauma. Types of enteral feeding tubes. Type of tube, placement, indications. Nasogastric tube, inserted via the nose into the stomach. Orogastric tube, inserted via the mouth into the stomach. Their indications are short-term enteral feeding. Orogastric usually limited to young infants only. Nasojejunal tube, inserted via the nose into the duodenum. Nasojejunal tube, inserted via the nose into the duodenum. Their indications are short-term enteral feeding, indicated if the child has trouble digesting food, cannot use his or her gastrointestinal tract, secondary to congenital anomalies, or surgery, or is risk for or has a history of severe reflux or aspiration. Gastrostomy tube, surgically inserted through abdominal wall into the stomach. Its indication is long-term enteral feeding when esophageal atresia or stricture is present. Jejunostomy tube, surgically inserted through abdominal wall into the jejunum. Jejunostomy tubes are indicated when gastric feeding is not tolerated. Methods of enteral feeding. A. Intermittent or bolus feeding. A specified amount of feeding solution is given at specific intervals, usually over a short period of time, such as 15 to 30 minutes. B. Continuous feeding is given at a slower rate over a longer period of time by using an enteral feeding pump to administer the feeding at a prescribed rate.
Gavage feeding procedure. Equipment. Gavage feeding tube selected according to the age and weight of the child. Please check page 99 as there is a table which clarifies the recommended sizes for nasogastric or orogastric tube. Stethoscope, prescribed formula or milk, non-allergic tape, small piece for mark, and a trouser shape for fixation. Sterile water for lubrication and flush, 5 and 10 syringe, a pacifier optional, non-sterile gloves, restraining equipment, towel or washcloth, pH testing strip, sterile gauze. Procedure: wash hands to reduce transmission of microorganisms. Prepare all needed equipment to save time and effort. Place the child supine with the head of the bed elevated to the high Fowler position if possible. if older child assist him to a sitting position. Then gloves to reduce transmission of microorganisms. Measure the tube for approximate length of insertion and mark the point with a small piece of tape. Please check figure A and B in page 100. We measure the tube to ensure that the appropriate length of the tube is passed into the stomach. We measure from tip of nose to the ear lobe and the xiphoid process, or midway between the xiphoid process and umbilicus, or from corner of the mouth to the ear lobe to the xiphoid process, or midway between the xiphoid and umbilicus in case of oral insertion. Then we put a mark. Lubricate the rounded end of the tube by sterile water to promote the passage of the tube and minimize trauma to the child's mucosa. And we lubricate by sterile water, not by gel, to avoid lipoid pneumonia. Place the child supine with the head slightly flexed. To allow for easy passing of the tube, enable easy swallowing, and ensure that the epiglottis is not obstructing the esophagus. Insert the rounded end of the tube into the clearest nostril and slide it backward and inwards gently along the floor of the nose to the nasopharynx until predetermined mark. To facilitate the passage of the tube by following the natural anatomy of the nose. Check the tube placement by the following. Number 1, inject a small amount of air 0.5 to 1 milli in newborn and 1 to 2 milli in older children. Into the tube while listening with a stethoscope over the stomach area and then withdraw air. Air can be detected by a washing sound when entering the stomach. Number 2, aspirate 0.5 to 1 milli of the stomach content to indicate proper placement. Number 3, test the acidity of the stomach with pH strips. Place aspirate on pH strip and leave it for 10 seconds. pH of more than 5 confirms the gastric placement. This in order to check the placement of the tube. The next step, notify physician if a gastric residue is greater than 50% of the previous feeding. Large gastric content may indicate retention due to formula intolerance or illness. Refeed unless aspirate are bloody, bilious, or predominantly mucus. Stabilize the tube by holding or tapping it into the chip. By a trouser shape, we stabilize the tube. To maintain the tube in the check formula temperature and amount. To be as the room temperature. Place the towel or washcloth below the chin and the chest to protect the clothes and the linens from emesis or secretion. Connect the syringe parallel into the tube. Pour formula into the barrel of the syringe attached to the feeding tube and give gentle push with the plunger to start flow. To prevent rapid distension of the stomach. Allow feeding flow slowly by gravity to avoid direct forceful pressure on the gastric mucosa. Pinch the tube by finger just before the syringe is empty to prevent air from entering the stomach. Flush the tube and catheter tip with distal water from 1 to 2 ml for newborn and 3 to 5 ml for older child. In order to clear the tube and prevent occlusion, clamp the indwelling catheter and remove the syringe to prevent loss of feeding. Place the child on the right position. To minimize distension, provide mouth care with gauze and distal water to prevent infection of the buccal mucosa. Record the amount, type of formula, and residual. Report for any abnormalities. Return the equipment and leave the area clean and tidy. Wash hands.
سلوى محمد أحمد, Clinical Instructor at Faculty of Nursing Pediatric Department. Equipment, prescribed formula, 60 ml syringe, a pacifier, optional, non-sterile gloves, towel, gauze, distilled water. Procedure. Steps. Wash hands to minimize infection or reduce transmission of microorganisms. Prepare the needed equipment to promote effective time management and organized approach to procedure. Don gloves. Place the child in supine position with the head of the bed up to 30 degrees. Measure prescribed amount of formula. Place a towel under the gastrostomy tube to protect clothes or linens from emesis or secretions. Verify proper tube placement. If external tube length is shorter than baseline measurement, distended abdomen, or high-pitched bowel sound, this indicates malposition. Rationale: to avoid complications associated with inappropriate administration of feeding. Attach 60 ml syringe and aspirate stomach content to check residual stomach content before feeding. Measure residual stomach content. If the residual stomach content more than 50% from the new formula, report to the doctor. Monitoring residual aids in preventing overfeeding and detecting early signs of feeding intolerance. Return residual to stomach if it is a small amount. Elevate tube and syringe to a level to deliver the feeding over about 15 minutes. This elevation level will allow for slow gravity-induced flow. Clear tubing with 7 to 10 millidistal water when feeding is completed. Rationale to rinse tubing. Apply clamp before water level reach end of syringe. Okay, as we done. Place the child in comfortable position to reduce transmission of microorganisms. Mouse scale. Making goes to cover all finger. Using distilled water. Cleaning inner aspects of the mouth, then lips. Wash hands. Then recording type, the amount and residual, and report for any abnormalities. Thank you.